Hey guys, my name is Dr. Ilman. I'm a physical therapist. I want to talk about different types of impingement that we see in the clinic. So number one is primary impingement. Then I want to talk about secondary impingement, then internal impingement, and finally I will talk a little bit about glenohumeral joint laxity. So primary impingement, we see primary impingement in those type of patients who are usually 40 years old or more than 40 years old, right? Their primary problem is that they go through degenerative changes in rotator cuff muscles, and as a result, that leads to primary impingement. Or they can also have an anomaly in the anatomical portion of their bone. Let's say the acromion process can be protruding out, which is, let's say, causing primary impingement. So it can be either anatomical anomaly, or it can be either anatomical issues, or it can be degenerative issues. For example, patients who are 40 years old or older who are going through degenerative rotator cuff changes. That's your primary impingement. Secondary impingement, on the other hand, are those patients who are usually between 15 to 35 years old. So their problem is mostly in the anterior side of the shoulder, right? They will come to the clinic, and after examining, you'll see muscle weakness in the front side of the shoulder. Their pain is also at the front side, right? And you'll see there are lots of, you'll see instability pretty much at the front side of the shoulder, not necessarily at the back, at the front. And internal impingement are those patients who are mostly an overhead athlete, like their pain location will be in the back. So again, internal impingement patients who are going through internal impingement, their pain location will be in the back, whereas patient who is going through secondary impingement, their pain location will be in the front side of the shoulder. By the way, in all impingement, you will see instability. Like impingement and instability goes hand in hand, because rotator cuff muscles, right? What does it do? What does those muscles do? They are a primary stabilizers, right? Now, as soon as you bring your arm overhead, your rotator cuff muscles are stabilizing your glenohumeral head, right? Like this is the glenohumeral head. As it is going up, your rotator cuff muscles are stabilizing it, right? Your rotator cuff muscles actually helps that glenohumeral head to go down, right? Now, if the stabilizers are weak, what happens is as soon as the glenohumeral, as soon as your humerus is going up, if the rotator cuff muscles are weak, then what you will see is that you will see a superior translation of the glenohumeral head, because the stabilizers are weak. They are not allowing the head to go down. Like if the rotator cuff muscles are strong and intact, it will stabilize the head, and as the arm goes up, it will help to bring the head down, right? Now, if the rotator cuff muscles are weak, then what will happen is as soon as you bring the arm up, you will see a superior translation of the head of the humerus bumping into acromion, right? Why? Because the rotator cuff muscles are weak. So another misconception that I want to clear out is that glenohumeral joint laxity, like if you're very hypermobile, that does not necessarily mean that you have instability. I will repeat that again. If you have glenohumeral joint laxity, or if you have a lot of mobility, that does not mean that you have instability. Instability comes when your rotator cuff muscles are weak. So again, when your rotator cuff muscles are weak, as soon as your humerus goes up, right, it's going to bump into the acromion. Because why? Because your rotator cuff muscles are not doing its job. Its job is as soon as you lift the arm up, rotator cuff muscles are supposed to be bringing the head of the humerus down. That's its job, to hold it and to stabilize it as the humerus goes up. Hope that helps.